Hello, guys. The case I have today is I have a patient. I had a patient, and her name is A. D. She is 66 years old, female, Caucasian. She came to the clinic by herself, and she looks good historian. She came up with the chief complaint of shortness of breath, recurrent wheezing, and kind of wearing tiredness. It's been going 2 weeks since she had this. Since she had this complaint, and the patient, she said, her symptoms is getting worse during the morning and feel better during the day, and she never had such kind of issue. She never diagnosed any asthma or any respiratory problem, and she's retired salesperson, depend on Medicare and retirement. Her husband is a store owner, and she denied that she never had a history of smoking. Her husband is never smoked too. She never used any drugs, and the only medical history she had is she got history of GERD. She used over-the-counter medication. She doesn't have that much complaint. Hyperlipidemia, and she got left leg surgery 20 years ago. She never been admitted in a hospital after that, and she denied history of asthma, COVID, or tuberculosis. She never traveled abroad, and the only family history she had is positive for respiratory. Is her mother is she's 85 years old, female, living by herself, but she got history of asthma. She's taking her medication. Rather than that, both like her daughter and his son, they are okay. Took only blood pressure medication, and she is immunization. She got up to date with immunization, pneumococcal and COVID. She got booster, and she got flu vaccine. And when we come to the her vital sign shows the blood pressure is 109 over 73, heart rate is 84, respiratory 20, and oxygen. Her PO2 is 96 on room air, temperature 97.6. She got her BMI is 28, a little bit overweight. Now the physical exam is the patient is she's alert times 4. She's feels a little bit distressed, but she can speak a full sentence, and she can explain herself. And tactile frematus is reduced to moderate degree, and when there is a bilateral chest wall wheezing on auscultation. And what we did was the patient peak expiratory flow. She is 62. So based on that, we order, and her blood work is chest X-ray, peak flow, ESR finding is 21, and her both neutrophils and eosinophils is high, ESR is 21. This is her blood work for her follow-up with primary. And my differential diagnosis is asthma is number one. The second is COVID rule out, and pneumonia. And based on National Asthma Education and Prevention Prevention, she is my final diagnosis is asthma by categories of moderate persistence asthma based on the AP flow. And I did treatment on her Advair HFA, or the combination of salmeterol and fluticasone, which is a combination of LABA and ICS. LABA is long-acting beta agonist, which is we cannot treat only for LABA, which is increase the days of the patient. We always combine either short-acting, or we have to combine with ICS, low-dose inhaled corticosteroids. What we did twice a day, 1 puff each time. and mostly give education about the patient, how to use the medication, and provide a proper guidance how to use inhaler, and talk about the importance, like if she's smoking, maybe sometimes deny, and how in quitting smoking. She denied smoking, but it's very important still. We teach, help the patient cope with the stress or environmental exposure, and show her how to peak flow reading, tell her kindness of like the numbers, and make suggestion the patient how to make an appointment with follow-up, and at the same time chest x-ray, and if she needed a referral to pulmonologist, and come back after 2 weeks to see how her progress is gonna be. This is my presentation. Thank you so much.